Hip disorders in the adult account for a large number of patients presenting to the orthopedic surgeon. It has been estimated that approximately 350,000 hip arthroplasties are being done every year throughout the world, and osteoarthritis of the hip would account for a vast majority of those. Hip fractures in the elderly afflict 5 per 1,000 age 70 to 79 and 20 per 1,000 age 80 to 89. With the proportion of elderly patients in the population increasing, the number of hip fractures being treated are likewise increasing. At a large orthopedic center, fractures of the proximal femur accounted for approximately 30% of admissions and for approximately 50% of hospital days in the orthopedic service. Problems about the hip are indeed not uncommon for the orthopedic surgeon to encounter. As outlined in the program, Introduction to the Musculoskeletal Examination, the examination of the hip likewise should proceed in an orderly fashion. The various gait abnormalities are discussed in the video program on gait examination. The abductor lurch or gluteus medius gait in a patient with a painful condition about the hip, or the Trendelenburg gait in a patient with weakness of the hip abductors are commonly noted gait abnormalities with hip pathology. It is very important to observe the gait even as the patient is walking into the examining room. Ideally, the patient should be dressed in brief-type shorts to adequately examine the hip. The basic equipment required will consist of wooden blocks, measuring tape, goniometer, neurological hammer, pin, cotton, tuning fork, and containers to test hot and cold, and a stethoscope. Inspection. The whole pelvic, hip, and thigh area should be inspected for any deformity, discoloration, swelling, scars, or cutaneous lesions. As well, any asymmetry of the buttocks, gluteal creases, or thigh muscles should be noted. The gait should be reassessed now that the patient is suitably exposed for the examination, again attempting to pinpoint the phase of gait which may be abnormal. Posture. Note the level of the iliac crests. Any obliquity of the iliac crests may suggest a leg length discrepancy, and if this is the case, wooden blocks may be placed under the apparent shortened extremity in order to assess the magnitude of the shortening. A more detailed examination of leg length will be done later in the examination when the patient is lying on the examining table. Observe the dimples overlying the posterior superior iliac spines. These again should be on the same horizontal line, and if not, there is an obliquity of the pelvis. The postural aspect of the lumbar spine should be noted at this time. An increase in the lumbar lordosis may suggest the presence of a hip flexion deformity. Palpation. Bony landmarks. To ascertain the underlying anatomy so that any pathology detected during the examination can be localized, it is necessary to identify the landmarks about the hip which are readily palpable. Being able to pinpoint a specific anatomical location allows one to infer other structures which are known to have a fixed anatomical relationship to the localized landmarks. For example, the sciatic nerve is one halfway between the ischial tuberosity and the greater trochanter. While the patient is still standing, attention is turned to the front of the pelvic region. Iliac crests. The iliac crest can usually be identified by the index finger even in fairly obese patients. By placing the index finger of each hand along each iliac crest, the examiner can assess whether the pelvis is horizontal or oblique. By following the iliac crest anteriorly, the examiner comes to the anterior superior iliac spine. When learning to do the physical examination, it is initially wise to mark off the landmarks with an eyeliner pencil, and most cooperative patients will allow the examiner to do this. With the identified landmarks adequately illustrated, they can be used as reference points throughout the remainder of the examination. Iliac tubercle. The iliac tubercle is the widest part of the iliac crest and is palpable about 3 inches posteriorly from the anterior superior iliac spine. Greater trochanter. Moving the examining hand straight down from the region of the iliac tubercle, the posterior aspect of the greater trochanter can be palpated. With further palpation, the top of the greater trochanters can be identified, and normally these are at the same level, and to find otherwise would suggest some pathology about the hip, such as congenital dislocation of the hip. Pubic tubercles. As throughout the examination, a brief explanation of what you are going to do will allay any of the patient's fears. Return to the anterior superior iliac spines and moving down along the inguinal crease or groin, the examiner can palpate a bony prominence just lateral to the symphysis pubis, the pubic tubercle. The two landmarks, the anterior superior iliac spine and the pubic tubercle, serve to identify the inguinal ligament which courses in a straight line between them. Palpation of posterior landmarks. This is best accomplished with the patient lying on the opposite side with the hip partially flexed. Posterior superior iliac spine. By returning to the iliac crest, the examiner can follow this posteriorly, and the palpable prominence which lies directly under the dimple, noted previously on inspection, is the posterior superior iliac spine. Ischial tuberosity. Starting at the posterior aspect of the greater trochanter and moving posteriorly, the examiner's fingers will encounter the prominent ischial tuberosity. Location of the ischial tuberosity is much easier if the hip is flexed. Having identified the bony landmarks, the examiner has a map with which to find one's way around the hip and localize aspects noted on inspection and palpation in relationship to anatomical structures. Palpation. Soft tissues. The examiner should, in an organized fashion, palpate the soft tissues about the hip joint. Starting anteriorly, the first area to be examined is the femoral triangle. The patient should be supine with the ipsilateral heel resting on the opposite knee. The femoral triangle is bounded by the inguinal ligament above, medially by the adductor longus muscle, and laterally by the sartorius muscle. Femoral artery. The femoral artery is palpable just below the inguinal ligament at about its midpoint. Remembering the vein-artery-nerve relationship, the locations of the femoral vein, nerve, and femoral canal can then be approximated. Lymph glands may be palpated in the region of the femoral triangle. Tenderness from an inflamed psoas bursa may also be elicited during palpation. Trochanteric bursa. To palpate the trochanteric bursa, the patient should lie on the opposite side with the hip flexed. The trochanteric bursa is that region that overlies the region of the greater trochanter, and tenderness to palpation in this region may indicate a bursitis or inflammation of the trochanteric bursa. Gluteus medius muscle. The region of the gluteus medius muscle extends upwards from the tip of the greater trochanter to the mid-portion of the iliac crest. Sciatic nerve. The sciatic nerve is located midway between the greater trochanter and the ischial tuberosity. In a slim person, the actual cord-like nerve may be palpated. Ischial bursa. The ischial bursa overlies the ischial tuberosity and may be tender if inflamed. Range of motion. Active. The examiner must always document the range of motion by measurement with a goniometer. Abduction. With the patient supine, it is necessary to stabilize the pelvis with the forearm across the anterior superior iliac spines, and thus any pelvic contribution to the movement can be detected. The normal patient will be able to abduct approximately 45 degrees. Adduction. Adduction is the patient's ability to bring the leg from an abducted position to the midline and then cross the leg, which involves some flexion in order to clear the opposite leg. The degree of adduction from the midline is assessed with a goniometer and in the normal is approximately 20 degrees. The opposite leg may also be kept abducted and the movement of the leg being tested from the neutral to its maximum degree of adduction can be measured, and the normal is approximately 20 degrees of adduction. Flexion. The patient should be supine with the leg in the neutral position and the hip is bent up towards the chest. In order to test flexion, one must assure that the pelvis does not rotate in order to contribute to the amount of flexion at the hip. If the hand is kept under the lumbosacral spine, any pelvic rotation can be assessed. Normal flexion is approximately 135 degrees. Rotation. Rotation of the hip should be tested both in extension and in flexion with the leg in the neutral position. It is essential that one does not use the foot in order to measure degrees of rotation, because there is rotation alone at the foot and ankle, and this does not involve any movement of the hip. Internal rotation is normally about 35 degrees and external rotation about 45 degrees. Extension. With the patient lying prone, stabilize the pelvis against the examining table by placing the forearm across the posterior superior iliac spines. Have the patient bend the knee slightly to eliminate hamstring contribution to extension, and then have the patient lift the thigh off the table. Normal range of extension is approximately 10 degrees. It is also possible to assess ranges of motion that are frequently done in activities of daily living, and their loss may limit functional abilities. Flexion and adduction. This is the ability to cross one thigh over the other thigh in a sitting position. Flexion, abduction, and external rotation. This is the ability to place the lateral side of the ipsilateral foot on the opposite knee. Extension. This motion can be assessed by the ability of the patient to get off the chair with his arms crossed on his chest while keeping his back straight. As discussed in the introduction to the physical examination of the musculoskeletal system, if active motion is limited, it is also necessary to examine passive range of motion, that is, the motion performed by the examiner without the aid of the patient. To do a proper assessment of passive range of motion requires a completely relaxed and cooperative patient, and a brief description of the purpose and nature of the examination to the patient will allay their fears and aid in their cooperation. If from the history or earlier parts of the examination one expects pain to be produced, the patient should be instructed to tell the examiner when they begin to experience pain. Gentleness by the examiner will assist patient cooperation, and if the examiner feels that a certain motion will cause pain, this should be examined last. If the patient complains of pain, always ask the patient to describe its location. Although the examiner is testing hip motion, the pain may come from the back or knee, and hence pathology other than in the hip must be sought. The point at which pain begins and the maximum passive motion achieved should be documented by means of a goniometer. Flexion. The patient lies in the supine position, and the line between the anterior superior iliac spines should be perpendicular to the trunk. The leg should be in a neutral position, that is, no abduction, adduction, internal or external rotation. Place one hand under the lumbar spine and with the other hand allow the knee to bend and flex the thigh towards the chest. The hand under the lumbosacral spine will also be able to detect any pelvic rotation, which is obviously not part of true hip flexion. Abduction. The ability to abduct the hip is extremely important for activities such as perineal care and sexual intercourse, especially in the female. The patient is lying supine, and again the legs are in the neutral position. Stabilize the pelvis with the forearm across the anterior superior iliac spines and abduct the leg from the neutral position, grasping the leg about the ankle. Some patients are sensitive to pressure about the ankle, and hence it is necessary for the grasp to be gentle. Again, the normal range of abduction is 45 degrees. A record of the ability to abduct the hip can also be kept by serial measurements of the intermalleolar distance with the hips maximally abducted. Adduction. The position is identical for testing abduction. Again, the pelvis must be stabilized and the leg crossed over the opposite leg. Since excessive soft tissue of the thigh may impede adduction, start with the opposite extremity in abduction, then adduct the extremity being tested. The normal is approximately 20 degrees. Rotation. Rotation of the hip must be tested in both extension and flexion, since limitation of rotation may vary in each of these positions. Rotation in extension. The patient lies supine. In the neutral position, the patella should point straight up to the ceiling. Grasp the tibia, then internally rotate the leg towards the opposite extremity. The midpoint of the patella must be used for measurement, as you cannot use the foot because there is rotation at the foot and ankle independent of hip rotation. External rotation is assessed by rotating the limb away from the opposite leg. Alternatively, rotation in extension can be assessed with the patient lying prone and the knee bent to 90 degrees. The tibia can be used as a lever and pointer, but remember that the motion being imparted to the hip and femur can be confusing. Pointing the tibia towards the other extremity causes external rotation of the hip and femur, and pointing it away from the opposite extremity imparts internal rotation. Rotation in flexion. With the patient lying supine, flex the hip and knee on the side being tested to 90 degrees. Assuring that there is no excessive medial or lateral laxity of the knee, the tibia can be used again as a lever to rotate the hip. By pushing the tibia towards the opposite extremity, the examiner is externally rotating the hip, and the number of degrees of rotation of the hip can be assessed by measuring the angle between the neutral position of the tibia and the end position. Likewise, internal rotation is tested by pulling the tibia away from the opposite extremity and measuring the degrees of rotation. These motions about the hip are initially confusing when learning to do the musculoskeletal examination. You can always confirm on yourself by palpating your own greater trochanter and performing the motion. Remember, when the trochanter moves posteriorly, the hip is externally rotating, and conversely, internally rotating when the greater trochanter moves anteriorly. Rotation in flexion can also be done in the sitting position, with the knee bent to 90 degrees over the examining table, and using the tibia again as a lever to rotate the hip. Neurological examination. The detailed neurological examination of the hip region is covered in the video program on the physical examination of the lumbar spine and the neurological examination of the lower extremities, but would normally be performed at this point in time in the examination of the hip. Special tests. Trendelenburg test. This test is designed to assess the functional activity of the gluteus medius muscle. The examiner sits behind the patient, who stands with weight evenly distributed on both legs. The examiner should place the index finger along each iliac crest. The patient is then instructed to raise one leg off the floor, flexing the hip up to approximately 90 degrees. The patient should keep the trunk perpendicular to the floor, as excessive leaning to the side of the supporting leg may negate a positive test. The examiner then observes what happens to the iliac crest on the side that is non-weight bearing. If the gluteus medius is functioning normally on the weight-bearing side, the pelvis on the contralateral or non-weight bearing side will remain horizontal or rise above the horizontal. This would be considered a negative Trendelenburg sign. If the gluteus medius on the weight-bearing side is not functioning normally, then the iliac crest on the non-supported side will drop below the horizontal, indicating a positive Trendelenburg test on the right side. Thomas test. It would seem that a patient with a fixed flexion deformity of the hip would not be able to put the corresponding foot on the ground or lie flat in bed. This is obviously not the case, and by increasing the lordosis of the lumbar spine, the patient is able to compensate for a fixed flexion deformity of the hip. The Thomas test is designed to detect and measure the magnitude of a fixed flexion deformity. In order to examine the right hip for a possible fixed flexion deformity, the patient lies supine and the examiner stands on the patient's right side. The examiner places his flat hand under the mid-lumbar spine. The patient's left leg is then flexed towards the chest until the lumbar spine is flattened against the examiner's hand. The patient then holds the left knee in order to maintain this position. The examiner then notes whether the right leg is lying flat on the examining table. If it is not, the angle of elevation can be measured and recorded as the amount of fixed flexion deformity of the hip. Two important points have to be considered when performing this test. 1. If there is a corresponding fixed flexion deformity of the ipsilateral knee, then obviously the thigh will not lie flat on the examining table. In this case, the leg being tested must be abducted to the side so that the lower leg is clear of the examining table, and thus the component caused by the fixed flexion deformity of the knee is eliminated. 2. If the flexion deformity of the hip is great, then as the opposite leg is brought up towards the chest, the leg with the hip flexion deformity may be suspended in the air, and this may be very painful for the patient. In this case, it is best to flex both thighs to the chest, and after stabilizing the spine and the pelvis, gradually lower the affected leg to the point of stopping and measure the magnitude of the fixed flexion deformity. Leg length discrepancy. If during the examination it is noted that the pelvis is not horizontal when the patient is standing with both feet on the ground, this suggests the possibility that one leg may be shorter. The examiner thus has to determine if the discrepancy is true or apparent. True shortening is due to an actual decrease in the extremity length either in the femur or the tibia. Apparent discrepancy is due to a fixed obliquity of the pelvis or a fixed flexion, abduction, or adduction contracture of the hip. True shortening. It is first necessary to measure true leg length. The patient lies supine and the pelvis should be horizontal across the examining table. Both legs should be in the neutral position or in a position perpendicular to the plane of the anterior superior iliac spines. A tape measure is then placed at the anterior superior iliac spine, and the distance to the tip of the lateral malleolus is measured. Many authors suggest measuring to the medial malleolus, but I find that excessive thigh girth or atrophy can influence the measurement. The measurement for each extremity is performed identically and recorded. If a true discrepancy is found, the examiner can then assess whether the discrepancy lies in the tibia or the femur. The patient, again lying supine, flexes the knees to approximately 90 degrees. The examiner then observes from the side. If one knee projects further anteriorly than the other, then the femur on that side is longer. If one knee is higher than the other, then the tibia on that side is longer. Obviously, this is an approximate assessment only, and it is necessary to obtain a radiological scanogram to more accurately measure bony length. Apparent leg length discrepancy. If a true leg length discrepancy has not been found, but it appears from observing the patient that a discrepancy exists, this may be due to an apparent leg length discrepancy. In this case, the legs are placed parallel to each other, and this is the usual position that the patient will assume on the examining table. The legs are not placed perpendicular to the pelvis or the line joining the anterior superior iliac spines. The measurement is then taken from the umbilicus or xiphisternal junction to the medial malleolus. This is done for both legs, and the difference will be the apparent leg length discrepancy if there was no true leg length discrepancy. Ober test. The patient lies on the side opposite to that being tested. The examiner then abducts the thigh as far as possible while keeping neutral rotation, flexion, and extension of the hip. The knee is flexed to 90 degrees. The leg is then lowered towards the opposite leg, and if the medial aspects of the knees contact each other, then the Ober test is negative. If the thigh remains elevated, that is, does not contact the opposite leg, then the Ober test is positive, and this signifies a tightness or contracture of the fascia lata or iliotibial band. Such a positive test may be found in myelomeningocele or polio. This completes the detailed examination of the adult hip, but remember that related areas such as the lumbar spine, abdomen, knee, and thigh must be included in the examination of the hip.